Our next speaker is leading innovative collaborative efforts to improve access to care and reduce barriers from social determinants of health. We're now joined by Dr. Karen DeSalvo, Chief Health Officer at Google Health and co-convener of the National Alliance to Impact Social Determinants of Health. She's also Adjunct Professor of Medicine and Population Health at University of Texas at Austin Dale Medical School. Dr. DeSalvo was National Coordinator for Health Information Technology and Acting Assistant Secretary for Health in the Obama administration. Prior to joining HHS, she was the New Orleans Health Commissioner. Dr. DeSalvo is a physician executive working at the intersection of medicine, public health, and information technology to improve the health of all people with a focus on catalyzing pragmatic solutions to address all the social determinants of health, and we're so honored that she's here with us today. Karen?
Well, hi. Thank you very much for having me here today. Can you guys hear me okay?
Okay, there's a little bit of an echo.
All right. How about now? Can you hear me now? Is that better?
That's better.
Perfect. Well, thank you so much. I'm really delighted that I get to follow the theme of my presentation because this is sort of the natural narrative that a lot of the country has been on. The accountable health communities work really sparked some more systemic and national interest in the efforts, but as you'll see from speakers who follow me, there's been a lot of private sector work and great projects that even date back decades, frankly, and personally did some work in addressing social drivers in our post-Katrina environment in New Orleans. But the information that I'm looking to share with you all today really takes a national perspective. Next slide. And I'm wearing my hat here as the co-convener of the National Alliance to Impact the Social Determinants of Health, also what we call NASDO. And this is an effort that I co-convened with former HHS Secretary Mike Leavitt to pull together stakeholders who were interested in working towards more systematically and pragmatically building a common understanding of the importance of addressing social determinants of health as part of an overall approach to health improvement, not only through the healthcare system, but more broadly in communities. And our work has been to really move towards creating a pragmatic, not only understanding, but way to fund sustainably and durably all of the sectors and work that really drive holistic, value-based, person-centered approaches to successfully impact the social determinants of health beyond demonstrations and projects that we might be engaged in doing. And I just would highlight three big areas that are important to us. One is that we do believe that the success of value-based care is dependent on attending to all the drivers of health, including the social determinants of health. And that secondly, breaking down silos at the federal, state, and local level and encouraging private sector collaboration, innovation, and partnership with the federal government is going to be essential to success. And that public-private sector collaboration is happening in local communities, but we have an opportunity to think about scaling and sustaining those, and I'll talk a bit about the funding of that in my presentation. Next slide. The active healthcare environment, as I said, dates back decades, but the work of the accountable health communities model really grew out of a lot of appreciation from the healthcare sector on its value-based care journey that there was going to be more to health and healthcare. Next slide. This idea that to get to health, we have to go beyond great medical care. What is reflected in this diagram is 20% of the health outcomes for an individual or a community, and really begin to think about addressing the social and environmental and behavioral factors that drive some 60% of health outcomes. And this is true not only because the country needs to advance the value-based care journey, but also has become more important because we are responding to a national health crisis of declining life expectancy now for 3 years in a row, which is related not so much to a single chronic or communicable disease like in the times of Spanish flu or the HIV epidemic, but more to broad underlying social drivers that are manifesting as the opioid epidemic or suicide and homicide. And so thinking about broad health generators and doing that in the healthcare environment in partnership with others is what really we're seeing happen all across the country. Next slide. And the National Academy of Medicine actually had a report last fall on integrating social care into the delivery of healthcare. I had a chance to sit on this convening group, and I wanted to share the framework that we came up with, these 5 A's. Just as you all are listening to the other presentations today and as you hear of models in the field, this is a way of understanding how to maybe organize the work that's happening and then think about in your own organizations how you might approach addressing the challenge of the social determinants of health. The 5 A's are, include those that are focused more on individuals and those that are focused more on community level action. And it always starts with awareness. You heard a lot of discussions a moment ago about the importance of good screening tools. There's also opportunities around using secondary data to understand the context of the lives of our patients and communities. NIHCM has done a screening brief that you could find on our website, and there are many other good resources in this area. But starting with awareness then drives the idea that we might need to adjust care based upon people's social drivers and contexts, that some systems are providing assistance to services for individuals. The work of the Accountable Health Communities model also brought to light this alignment of sectors like the food sector to identify gaps and/or improve synergies, and then finally advocacy where necessary to fill gaps. And the next slide shows some examples in the transportation area in each of these 5 A's. And so, for example, in awareness, the beginning of that would just be to ask people about their access to transportation. Adjustment would involve reducing the need for in-person healthcare appointments by using telehealth, for example. For assistance, it might be that some systems begin to provide transportation vouchers or rideshare to support access to the healthcare environment. And alignment would be really understanding how there can be community ride sharing or time bank programs. Advocacy would be a higher order of community engagement, which would work to promote policies that fundamentally change the transportation infrastructure within the community. Next slide. Some of the reason that I think the social determinants of health work is really taking off now in the minds of healthcare is not just because of the value-based care journey or the understanding of the major drivers of health and morbidity and mortality in the U.S., but we have better insights because of the data infrastructure and an opportunity to really create better appreciation using secondary data of needs, but also link people to services. Next slide. I would just wanted to highlight 2 big areas in here, one of which is that in this data landscape, there are a lot of tools that have been developed that the Siren research group has a wonderful report out about, the community resource referral platforms that are some of these privately developed interoperability platforms that connect healthcare and community-based organizations and sometimes also the consumer. Many state-level health information exchanges are stepping into this space as well as some of the electronic health record companies are creating these kinds of platforms. But it's also raising some new problems to solve in the space as we add an interoperability layer and want to make sure that we're getting the right information to people, including the first is appropriate consent, especially stepping outside of typical HIPAA-covered entities. The second is ensuring appropriate digital identity. And the last set of problems relate to making sure that we're creating an open interoperability space, leveraging application programming interfaces and standards like FHIR that are widely available and will be easier to implement. Some of that is in streamlining the collection of social determinants of health profiles to prevent people from having to prove poverty multiple times, making it easier for community-based organizations to connect with each other and with the healthcare system, and finally to move towards streamlining eligibility and enrollment through better connections with social services, administrative data resources. These are things that NIHCM has begun working on in partnership with many others in the public and private sector. Next slide. I want to move into the last section, which is to talk about financing, because doing the care models and experimenting is a very active space, but also, and so is this active space of learning the best ways and the most appropriate way to respect privacy, but also share data. But the big hang-up has been that we haven't had a sustainable financing model for these projects to move beyond demonstration or pilot phase. Next slide. I think the message from the top from Secretary Azar from the fall of 2018 was a really powerful one, where he said that in this statement, which you can read a snip of his speech, which would be available on the HHS website, that really there's more than social determinants being abstract, and that it's very tangible and frightening for many people on the front lines. And he lays out in this speech the idea that it's going to be more than just thinking of payment policy, but there are broader needs to consider policy and support in the human services world, not just in the healthcare world. Next slide. The speech by the Secretary and the work that's happening all across HHS really reflects some backstory, including a lot of private sector experimentation and innovation, which you'll hear more about in the presentations that follow me, bipartisan congressional action, particularly to provide more flexibility for the Medicare Advantage programs, to do more to serve seniors who have things like loneliness or transportation or food security challenges. Health and Human Services, beyond Center for Medicare and Medicaid Innovation, there are a host of projects happening across HHS, some of which started in the Obama administration and have carried forward in the Trump administration, again reflecting a nonpartisan or bipartisan nature of this work, not only in the value-based care agenda, but in the human services work. And finally, a lot to learn from the states. The state of North Carolina gets a lot of attention because it's got a really innovative approach to a rapid test and learn of what makes a difference in the health and lives and cost to people on the front lines. But a number of other states, like Rhode Island or Oregon or New York, are far along in this pathway. And I think the more we can learn from those state innovations, I think the better off we're going to be going forward. Next slide. The final thing I wanted to mention in financing is that the important place we are right now as a country is that we've been thinking of how to transfer dollars from the healthcare system or to provide more flexibility in benefits packages in public or private sector insurance, or CEOs are writing checks out of their pocket to buy an air conditioner for somebody's house who's been in and out of the ER a lot because they have asthma and they need a conditioned space to sleep and live. These kinds of ad hoc models are typically driven from literally the pocket of the healthcare system, but avoiding medicalization of the social determinants of health really means that a person won't be bound to an insurer or a healthcare system to get their social needs addressed, but rather that there is going to need to be a way to address this wrong pocket problem. Some of that is in looking at how to share gains when cost goes down, not just seeing that those gains accrue to the healthcare system, but that they're shared with the social services and community-based organizations that are supporting patients and communities. Oregon is a state that has been doing a lot of thinking of this and work in this in Medicaid, so have parts of the New York State Medicaid program. But I think we're just beginning to understand how to respect the partners and not just treat it as a contract, but think about moving towards shared gains as we reduce cost from addressing social drivers of health. There's also an opportunity to better understand how to pool funding from the public and private sector. This may mean blending and braiding of funds, so not exactly putting it all in one pot that pays out for services, but certainly places like Rhode Island have been already understanding how to maximize the federal rules around where transportation dollars can be aligned with Medicaid dollars, as an example. But there's plenty more that I think we can learn, and hopefully that the federal government and states will begin to create more flexibility so that services really truly wrap around the person and the community, and we are able to make the right investments in social care organizations, which is really the last comment I'd make in this space, and that is many may be aware that, as is shown in this graphic, this bar chart on the right, the U.S. Is in the middle of the pack when you combine healthcare and social care spending. We just spend much more on healthcare than on social care. The current movement in social determinants of health funding would sort of push those dollars into health care and have them then pass them on to social care. Another approach might be that we would want to invest more in the social care sector, allowing it to modernize, to become more digital, to have a stronger business infrastructure, very much along the way that we require transformation and modernization of the healthcare infrastructure to develop more value, to be able to do that for the social care infrastructure. The last slide really is just a request and maybe particularly a call to action that NASDO has been keen to begin to lift up, and that is that we have a lot of great patchwork efforts happening all across the country. What we need is a national strategy, given that morbidity and mortality from the social determinants of health seems on par with prior disasters like the Spanish flu at the time of World War I or the HIV epidemic. We should be that intentional as we try to create synergies and learn to advance the field from lessons learned, including what works and doesn't work, to maximize the effectiveness and efficiency of our resource use, so we're not repeating things that we already should have known and trying new models that we know work in other areas and not taking the opportunity to scale. Clarifying the evidence base systematically by leveraging the talents of the NIH and PCORI and other national resource entities, and building this with community, not for community, as we're thinking of being intentional about reducing disparities and not creating products or care models that might unintentionally drive people out of care or out of services. And I look forward to questions when we get to that section, and I'm going to now turn it back to the moderator. Thank you very much.